All right. Good morning, everyone. I think you all know who I am. So today we're going to be having EMCCM conference. I want to thank the EMCCM team, specifically Drs. Udad, D'Souza, and Lammert, who helped me get this presentation together. All right, let's start with the case. It's a downstay case, so our gray phone rings. It's a 3 to 11 shift on a cold winter night. And all you're getting is male, mid-50s. He had multiple episodes of syncope today. He's bradycardic to a heart rate in the 20s. He's hypotensive to the 70s over 50s. EMS gave 2 amps of atropine with minimal response in his hemodynamics. They started hanging fluids. They're 5 minutes out. On your initial assessment, we go through our ABCs. So airway is patent after you suction the vomitus in the oropharynx. His breathing is shallowed and labored. For circulation, he has cool, clammy extremities. He's obtunded on your disability assessment. He's not following any commands. And on your exposure assessment, you notice a head laceration. It's superficial. There's no active bleeding. Here's your initial vitals. There was no recorded temperature for this patient, so take that as it is. So you notice the bradycardia, the hypotension. He's saturating well on room air, and there was a glucose. It just read high, so above 600 milligrams per deciliter. All right, so just based on that brief preview, what is our preliminary problem list? Just shout out anything that you think should be on this list.
Bradycardia.
Bradycardia, great. What else? Hypotension, hyperglycemia. What else? Altered mental status, love it. Head trauma, love it. Anything else?
Beta blocker.
Possibly. I heard someone uttering something else. It was given in the history in the notification. Syncope, right? And when we kind of like group them together, we may like together, what's a unifying diagnosis for our first 4 problems in this list? What's one common denominator, one umbrella term we can use to shock? Yeah, this patient is in shock, and that's like the important thing to recognize. And we'll go into the type of shock he's in, but recognize that this is a critically ill patient in shock. Okay, so what initial interventions do you want to do for this critically ill patient? IVO2 monitor, great. What else? Pads, love it. Fluids. Labs. Ultrasound, temperature. I heard EKG, someone said. Last one. Great. If glucose, if you haven't gotten already, EKG was said. Ultrasound, right? Grab your ultrasound. It might help in our diagnostic uncertainty here. And then continue with fluids as your first line agent to try to get volume expansion. Okay. Anything else that you're considering? Maybe you don't want to do right away, but you're starting to think about it. It's in the back of your mind. Maybe you're asking your nurse to go grab some stuff that you may need later on. Okay. Intubation supplies, love it. Suction, if it's not set up already. Like in real life, it was not gotten, but yes, and you know, if it's a critically ill patient and like they're not like getting the probe like to get the temperature probe, I think it's okay. But yes, it's going to help complete your clinical picture later. Crash car. So what in the crash car? Like what meds?
Epinephrine.
Yeah. All right. So you're starting to think of pressor support or something. Yeah. Okay. All right. Good. So let's hold on to those ideas. I just want you to start like thinking about it and keeping that in mind.
Pressor.
Happy? Yeah, we'll get into more of that later, exactly. But I want you to start recognizing that's where it's heading. Okay, so we get our HPI. This is more or less like word for word in terms of what was documented in the IPN. So you have a 56-year-old gentleman. His medical comorbidities include hypertension, diabetes mellitus, dyslipidemia, and CAD. He has HFrEF with reduced ejection fraction, AFib with RVR, status post and ablation. He was coming in by EMS after syncopal episode and was noted to be bradycardic. And now you're starting to get more of your history. So he says he did not take, or actually the collateral was from family at this point, who arrived shortly after he did. He did not take his diltiazem for several days and he felt weak. And then this morning he took a dose of his diltiazem shortly after he started getting these episodes of syncope and altered mental status. From the notification, you already knew he was bradycardic and hypotensive. And they gave atropine and fluids, but there was really minimal response in his hemodynamic or mental status. Okay, so let's move on to our exam. Our general appearance, he's diaphoretic, he's ill appearing, he's toxic appearing. On our Hent exam, he has pupils that are equal and round and reactive to light. There is this forehead laceration without any active bleeding, and he has dry mucous membranes. On your cardiovascular exam, you can palpate a slow and fairly regular pulse. It's weak but thready, and he has cool clam extremities. His respirations are shallow, but on auscultation, they're clear. His abdomen is soft, non-tender, and lower extremity exam does not reveal any sign of fluid overload. There's no like dependent pitting edema. Our neurologic exam, he's initially obtunded, not following commands. His GCS is 10, E3, V3, M4, and there's no yet improvement on reassessment. Okay, so here's our initial EKG. Does someone want to volunteer? I don't want to call on someone. Someone volunteer or soon to be voluntold?
Atrial flutter.
Okay, so go through it systematically. How do you approach any EKG?
Look at the rate.
Sure. What's the rate? Just approximately.
I think it's like 30.
Great. So 30, somewhere between 30 and 40.
And then look at normal sinus. They look for a P wave.
Yeah. Do you see P waves?
No.
Okay.
Axis. I think so. Yeah. Like, what?
Okay. What makes you think it's left axis?
Well, it goes down in one, but
Yeah. So it's down in 1, but it's also up in 3. And it's kind of isoelectric in 2 in AVS. So that would actually be more of a right axis, but like borderline right. You said no P waves. What other wave morphology do you see? It kind of looks like a sawtooth pattern almost. Yeah. So what do we call those?
this.
Yeah, flutter waves. You said flutter, right? So we see it's slow. It's about 30 to 40. There's no P waves, but we do see flutter waves. What about the complex? The actual like QRS complexes. Is it narrow or wide?
Well, at certain points, looks narrow.
Yeah, overall it looks narrow. So it's a narrow complex bradycardic rhythm with flutter waves, maybe borderline right axis, and then just anything screaming out at you in terms of the ST segments or T waves. No, not really, right? There's no ST segment elevation. The one thing I would say about the T waves is they do look diffusely flat, right? And so we kind of culminate this together. And so it's atrial flutter with slow ventricular response and maybe diffusely flat T waves. Okay, great job. All right, ultrasound, yes.
Just differentiate. I mean, maybe it doesn't really clinically matter, but a flutter with slow ventricular response versus a junctional escape rhythm, like how are different in this thing?
So for a junctional escape rhythm, in my mind, it's really just presence or absence of flutter waves. Because if you otherwise, right, oftentimes with a flutter, if it's a not a variable block, and so like here it looks like it's like between a 4 and 5 degree block for the atrial flutter, it looks quote regularized, and so that keeps it regular. Oftentimes it will not be if it has variable block, but for junctional rhythms, it should always be fairly regular, and they should always have absence of flutter waves or any other kind of P wave morphology. Does that make sense? And then you can also kind of correlate it with the rate. If you think it's a right infrahis Purkinje like junctional rhythm, it should map out to, depending on where you think infranodal, infra-AV node is coming from, it should kind of match up to that target heart rate as well.
Like 1 to 7, like there's like 7 P waves.
I can't count exactly. It's like, yeah, 5. So it actually looks like it might be a little bit variable, so between 5 and 6, but like overall, even when you were just palpating a pulse, it felt fairly regular, even if it was technically a variable block. Okay. Ultrasound. So I actually went through with Hannah like the 2 calendar days that this patient was in the ED, and unfortunately there was not any recorded images, but I do think it would be prudent to at least discuss what you would look for on your ultrasound in this bradycardic hypotensive patient. Squeezed. Great. So pump function, I'll like classify it as an umbrella term. So look at your ejection fraction, look if there's any like clinically significant valvulopathy that's contributing to a reduced ejection fraction. What else? Great. So volume status. We can look at the IVC. Maybe if you already have your probe in your hand, look at the lungs. Do you see like a ton of B lines or large pleural effusions that would suggest a fluid overloaded status? And then one more thing we kind of intuitively always do, but maybe don't always verbalize it, is like look for easy reversible causes, right? That would explain this clinical picture. So what would be a potential reversible cause for bradycardia, hypotension, maybe pump failure? Louder?
The bradycardia.
Tamponade, excellent, right? You see a big, juicy, pericardial effusion there, and they're going into obstructive shock, and they're bradying down, and they're getting hypotensive because of it. Great, you found a reversible cause, and you get a good procedure. What else? Yeah, right heart strain. If you see McConnell sign, D sign, just like a big dilated, RV that's under tremendous stress, and this patient is crashing, or does, lose pulses, you could do something about that. You can push a thrombolytic. So that's a reversible cause you can look for. And then one more, also like kind of clinically and technically challenging to do, but regional wall motion abnormalities, right? If you just see a totally dyskinetic or akinetic portion of the heart, and it clinically may look like an OMI, you can do something about that. You can call, get an interventionalist down there and get them to the cath lab. So these are things that it, just think about it, but in terms of identifying easy reversible causes, looking at their pump function and looking at the tank, seeing their volume status. All right, so we have this bradycardic hypotensive patient. There were initial interventions that didn't really improve their hemodynamic status or mental status. What are broad differentials that you think could be going on here? Tox, great. What else? So some kind of toxidrome or overdose. What else? DKA, love it, right? He's hyperglycemic. HHS, he's altered. MI, love it. Electrolyte derangements, which one specifically? Hyperkalemia. I'm going to start bringing them up. Sepsis, right? With decompensated shock, overdose, toxidrome was said. Could it be a hypothyroid or myxedema coma, some kind of endocrinopathy at play? An Addisonian crisis. Neurogenic shock, one we don't probably typically think about, but we'll discuss more later. Hypothermia with bradycardia and hypotension, right? In the absence of getting that initial temperature. Cardiogenic shock will include MI, decompensated CHF, DKA, HHS, hyperkalemia or renal failure was said, and then others, which we will eventually get to as we progress. Okay, so it's time to reassess. You have an EKG that looks like this, and you have a patient that looks like this, and your initial critical interventions did not do much. Now it's time to go back to what we discussed earlier. What are you asking your nurse to do? What meds are you asking them to bring up? What is your escalation of therapy here for this critically ill, hypotensive bradycardic patient with a poor mental status? So just to recap. So EMS gave atropine and fluids, heart rate still in the 20s. It was documented as 28 when he first came in, and he's still hypotensive. So what do you think the team should reach for now? Just some of the meds. Sorry? Great. So pacing is something to consider. And that's actually what the team did. So they put on the pads. They asked the nurse to get an epi drip, and they set it at 3 micrograms per minute. And they gave 2 grams of calcium. They chose calcium gluconate, and they gave it as a quick bolus from the bag. And what happened? Heart rate improved to the 40s. And I'll add a little caveat there. They set their rate when they were pacing to 80, and they actually increased their capture to 90 milliamps, but the heart rate was only going at 40. So what do you think is going on here? You're setting your rate as 80, you're going up pretty high on your electrical capture, but the heart rate's in the 40s. What are we seeing at play here?
Not the right amount of anions and cation difference to get the heart to contract.
Excellent. So that's like one of the physiologic bases that would explain. But what do we call it? What are the terms at play here? So we have our, I'll make it, I guess, paint a different picture. On your monitor, it says a heart rate of 80. But when you palpate a pulse or look with your ultrasound, the heart's only going around 40. So it's a mismatch, right? We have two phenomena at play here. There's electrical capture and then mechanical capture. And electrical capture does not always mean there's mechanical capture, but the other way around is true, right? So all that means when you see electrical capture is that, right, there's a current going through some myocyte that's capable of, initiating an action potential initiates it, but that doesn't mean necessarily it propagates and you get a full, like, real meaningful contraction. And so that's what we call electrical capture without mechanical capture. And that's something to be cognizant of, that, just because you're seeing a heart rate of 80 on the monitor does not mean that that's what's happening in reality. So always confirm mechanical capture with electrical capture, either via ultrasound or old school by putting your hand on the radial pulse. Okay, so they give some calcium gluconate. The rationale for that was they got more history from family at this point that he took a calcium channel blocker, a long-acting calcium channel blocker. And so they wanted to give some elemental calcium to try to reverse that blockade. They're starting pressors because he's failed fluid resuscitation at this point. And they're pacing him, but albeit unsuccessfully. And so his heart rate's still in the 40s. He's still hypotensive. What do you want to do now? Who would transvenously pace this patient at this point? Yeah, potentially. What about, so you, like, this is a critically ill patient, your nurses are great, they get a line, they shotgun labs, your rapid comes back at this point, and you see a cave 7. Would you still transvenously pace this patient? So, okay, so good. So, right, as you get more data and the clinical picture is shifting, you can assess and reassess your interventions. And this is like actually how it played out in real time. So we'll get more into pacing and the later. Okay, so at this point, what do you want to do with that critical lab value?
Yeah, guys, hyperglycemic, altered, maybe has calcium blocker, and it's potassium 7. So I think, could it be DKA? I don't know. We don't have the rest of the lab.
Doesn't matter if it's DKA right now?
No, but like,
yeah, so throw a K cocktail at him, and that's what they did. So right, he got some fentanyl, he got 50 mics of fentanyl, he got the 2 grams of calcium gluconate. He was being paced at 80, but only had mechanical capture at 40. And at this point, they give him nebulized albuterol, 15 milligrams. They give him a push of regular insulin, 10 units, no D50 because the sugar was well over 600. And they start an insulin drip, or they order an insulin drip. They empirically give 2 milligrams of IV glucagon and 2 grams of magnesium sulfate. And that actually improves his hemodynamics. So his heart rate improves to 60s. He's still hypotensive, but less so. And at this point, you actually start to see an improvement in his mental status. Okay. So workup and consultations. What do you want? What info do you want? Okay, MICU. So 3 consultants you should get on board. ICU is one of them. So labs, right? You want labs. All right, so let's get our labs. We're going to get Rainbow Labs. I heard consultation, so let's just go through them. So we want to get ICU. What other consultants do you want on board? Cardiology, one more that you're...
Yeah, hypothermia for shock and
Yeah, nephrology. Possibly this patient needs an emergent hemodialysis. All right, so those are our consultants. What other imaging tests do you want? Great. So POCUS, if you didn't do one already, chest X-ray, right? And then a CT. This patient has had trauma, and I don't know if I actually mentioned it, but he is on anticoagulation, so he needs a head CT. Okay. And then our 3 consultants: cardiology, critical care, and nephrology, possibly for emergent hemodialysis. All right. So here are our results. These are the lab values you get. I'll make it a little easier for you. Does someone, in descending order, just try to take a stab at it? How do we interpret this VBG? And we can move along. So starting with the VBG. Yeah, so it's an acidosis. Is it a hagma or nagma? Great.
I see that there's acidemia because the pH is below 7.3. Then I look at my PCO2 to see that it's slightly elevated, but not critically elevated. But it also doesn't look appropriately compensated. If it were appropriately compensated for metabolic acidosis, I would look at the last 2 digits of the pH and expect my PCO2 to be about 27. And I, sorry?
He's applauding.
Oh,
Yeah.
and then I go down to the EMP and I look at the anion gaps and it's elevated. A normal anion gap would be about 12, 13, 14. It's about 5 above a normal anion gap. And I look at the lactate to see that it's 5. And I go through my CULT differential for lactic acidosis, ketones, uremia, lactate, and toxins. And I see that lactate is making up about how much I would expect of the anion gap above normal, right? 19 is about 5 above 14. 14 is normal. I would say, okay, there's a difference of 5 there. So lactate is 5. So that's making up most of my anion gap. So I have a lower concern for like a ketoacidosis or like toxic alcohols. And then I look at the uremia and it's 27. So I can say that this is probably a poorly compensated metabolic, high anion gap metabolic acidosis that is primarily a lactic acidosis.
And so there definitely is a metabolic component at play, but would you say there's also a primary respiratory acidosis given the uncompensated?
I would.
Yeah, and that's actually the primary process. So it's a primary respiratory acidosis with a secondary metabolic acidosis with an elevated anion cap. But that was, sorry, primary metabolic acidosis with a concomitant
Yes.
respiratory acidosis. Yes. Excellent graph. BMP. So you kind of hit some of the markers there. What else what do you think of this sodium? Just a quick teaching point. Yeah, you got to correct it. So he's pseudo hyponatremic. When you correct it for the sugar of 700, it's actually normal. Corrected would be 138. What do you think of this creatinine of 2? So sorry, I didn't put a date, but these labs were in mid 2025. And if you look in the bottom right corner, you see his baseline labs where they were 2 years prior. So take that with a grain of salt. But what do you think of this creatinine? What are our different options for what's going on here? All right, so it's either an AKI, right? He's critically ill, right? There are multitude of reasons you can have an AKI. It could be CKD, right? Progression. It's been 2 years since his last baseline renal function, or AKI on CKD. In his hepatic panel, he has a new transaminitis with a hepatocellular injury pattern. If you calculate his R factor, it comes out just above 3. Nothing really on his CBC. There's no leukocytosis. His H&H is stable when you trend it. His coags are showing a mildly elevated INR, possibly in the setting of his DOAC use. Could be synthetic liver dysfunction, right, if he has the transaminitis. His BNP is elevated, but it's chronically elevated, as you can see. And then his beta-hydroxybutyrate is showing minimal ketosis. So it's hyperglycemia, but not in DKA. All right. Here's your chest x-ray. Does someone want to take a stab? Okay, so maybe there's like a little bit of congestion. I would say more so on the like lower zones of the lung fields compared to the higher ones. But it's really mostly just concentrated at the highlight. You don't see what we call like cephalization, right? The expansion and really being able to track those pulmonary vasculature out to the periphery. Maybe it goes a third of the way, halfway, but not all the way. What else? Cardiomegaly, definitely. Are there large pleural effusions? Not really, right? You can see the costophrenic angles. They're not overtly blunted. Yeah, it's the like the positioning, right? It might not have been an ideal positioning. The airway actually looks fairly midline, but maybe it's kind of like slumped over when they're doing this, and so the diaphragms are elevated. The read was just no evidence of acute pleural or pulmonary pathology and large cardiac size unchanged. But I would say not overtly fluid overloaded just with this piece of data alone. All right, so we got our critically ill patient, we resuscitated him, we're getting an improvement in his hemodynamics and mental status. What's our updated problem list at this point?
Say that again?
I get you. So based on the labs, basically the only new information we got was from the lab. So what are our contributory factors at this point? Hyperkalemia, liver injury, and renal insult, we'll call it. So we've resolved our cardiogenic shock at this point temporarily, but we now have hyperglycemia, hyperkalemia, and renal dysfunction, which can either be an AKI, CKD, or AKI on CKD. Yes, Graf.
Question, how do we resolve our cardiac?
That may be a little subjective, but I would argue if his hemodynamics have improved to the point where his mental status wakes up, we're definitely heading in the right direction. Whether we say it's resolved or not, I guess might be semantics. But I guess that problem's been addressed and it's still underway. And now we have these new things we have to consider as well.
The one thing I would say is I wonder if we could group our hyperkalemia and AKI versus CKD as problems that are secondary.
Correct. This does not give like correlation or causation. I guess it's more just listing the problems, but as you're appropriately doing, you have to kind of make it paint or fit into the bigger clinical picture. Yes. Okay, moving on. So we consulted cards, right? Cardiology was consulted. They wrote actually a really nice, beautiful note, but I tried to keep it simple here. So this was their overall impression. Atrial flutter with slow ventricular response, likely multifactorial from possible AV nodal disease, AV nodal blocking medications, and hyperkalemia in the setting of uncontrolled diabetes mellitus, secondary to medication noncompliance. And the relevant recommendations that they gave were to maintain pads on the patient, repeat a K cocktail that was given earlier, get a MICU eval for the critical hyperglycemia, hold all of his AV nodal blocking agents, to continue trending his labs and lights and try to wean him off pressure support if his hemodynamics allow for it. At this point, after cardiology saw him, his heart rate and blood pressure are improving. It was stable for him to go to CT, and he got his CT head. I apologize, it's not the full axial imaging, but anyone see anything concerning? No, there was no acute intracranial hemorrhage or large territory infarct. So unremarkable CT head. All right. So at this point, kind of summarizing. So we have a patient who came in decompensated cardiogenic shock. He was resuscitated with intravascular volume expansion. The only recorded part in the notes is actually the 900 cc's of fluids given by EMS. There was nothing ordered in the chart to suggest he got additional fluids, though, as we all know, oftentimes things are happening, right? Like nurses are very proactive in hanging fluids. So I suspect from what I remember, he did get additional volume expansion. It's just not documented. So I apologize. I can't give a number to that. He had his treatment of his underlying Brady dysrhythmia with chronotropic and inotropic support from the epinephrine. He got treatment for the underlying AV nodal blockade with IV calcium gluconate and the glucagon. On his med list, he was also on metoprolol succinate, 200 milligrams metoprolol succinate. He got treatment for the electrolyte derangement. So the hyperkalemia was given a K cocktail. The hypomagnesemia, he was hypomagnesic to 1.5. They gave him 2 grams of magnesium. And then they started addressing his critical hyperglycemia by putting him on an insulin drip. And then his disposition, he was admitted to the CCU for close monitoring and a decision on whether or not he would be a candidate for ablation versus a permanent pacemaker. All right, so that brings us to our final diagnosis. Does anyone know what is going on here? BRASH. So this is BRASH syndrome. So BRASH syndrome is an acronym. It stands for bradycardia, renal failure, AV nodal blockade, shock, and hyperkalemia. And so our main focus for the talk today is we're first going to briefly rationalize how to approach your unstable bradycardic patient, and then focus the rest of our time talking about BRASH. Specifically, we're going to go through the pathophysiology of BRASH, the diagnosis, the management, and then the crux, I guess, of the talk will be talking about the role of transcutaneous or transvenous pacing in the management of these unstable patients. So starting with our approach to the unstable bradycardic patient. way I think of it, there are 6 etiologies, 6 classifications that you can kind of group every unstable bradycardic hypotensive patient into. Does anyone want to take a stab? So I'll start it off. Infectious is one. So if you think of like Lyme disease, where you get myocarditis, or sepsis with decompensated shock, all right, those are infectious etiologies that would cause someone to be both bradycardic and hypotensive. What's another one? Tox. So tox is going to be one of them. That's later. What else? Neurogenic. So high-level spinal cord injury above T6, you get the disruption of the sympathetic chain, and you lose that sympathetic tone. So you can become bradycardic and hypotensive. What's another one, Evans? You said it earlier. Sorry. So like cardiac, I like describe it as structural, anything where there's pump failure. So inferior MI, where you blow out your AV node, heart block, pump failure from advanced CHF or significant valvulopathy. Someone said toxicologic, think of your ABCD. So alpha-2 agonist, beta blocker, calcium channel blocker, and digoxin. There's environmental. Your hypothermic patient's going to be bradycardic and hypotensive, and then our endocrinopathies. So this is just one way to kind of puzzle together. When you have your unstable hypotensive bradycardic patient, try to think of all the etiologies that could be going on at play. And then your approach. Your approach is always the same. Put on the pacer pads, get your EKG, and follow your ACLS bradycardia algorithm until you can get more information and figure out what's going on to address the specific factors at play. And I won't go, for the sake of time, I won't go into the algorithm, but you should always be thinking like stepwise in this approach. All right, so for BRASH syndrome, a brief history. In 1984, experiments studying how calcium channel blockade potentiates the negative cardiovascular effects of hyperkalemia was done using animal models. The earliest case report that kind of noted this phenomenon of hemodynamic instability with hyperkalemia was first reported by Lee et al. In 1986. In 2016, Josh Farkas published an online PulmCrit article, I'm sure many of you are familiar with, in which he actually coined the term BRASH. The following 3 years later, the first case report was published in 2019. And then in 2020, Farkas et al. Published a literature review attempting at combining the scattered physiology that at this point had very much been piecewise into a single umbrella term that would describe a unique clinical syndrome. 2021 saw the first letter to the editor, which argued that BRASH should be recognized as a separate, distinct entity that standard ACLS algorithms kind of failed to properly address and treat. And it kind of shifted the focus from interrupting a vicious cycle at play as opposed to handpicking specific problems to treat. And then in 2023 was when the first systematic review was published, which, albeit given the limited data that it had at the time, they started getting cohort level data and were able to ask important clinical questions that guided future practice and management. And so now we're going to discuss the pathophysiology, the diagnosis, and management of BRASH. We're briefly going to highlight the management of toxic ingestions as opposed to therapeutic ingestions of beta blocker and calcium channel blockades, and then spend the rest of our time talking about the role, if any, of pacing in these critically ill patients. So, BRASH is a syndrome, right? A syndrome is a collection of signs and symptoms that predictably and consistently occur together. BRASH encompasses a synergistic process that involves AV nodal blockade, so think of your calcium channel and your beta blockers, that directly cause bradycardia through their AV nodal blocking agents, as well as indirectly cause renal hypoperfusion due to decreased cardiac output, which in turn results in hyperkalemia and worsening bradycardia. Contributing factors include non-selective beta blocker medications and hyperkalemia due to the NAK ATPase inhibition, reduced renal clearance of other culprit agents due to your decreased GFR. And together, this really culminates into a vicious cycle of bradycardia and hyperkalemia that begets one another. ACE and ARBs are also independently contributors because they also worsen renal function and can cause hyperkalemia in themselves. BRASH syndrome is a clinical diagnosis. Your typical patient profile is going to be an elderly patient with significant medical comorbidities. They're often on polypharmacy, including AV nodal blocking medications with or without RAS inhibitors. And then the real trigger is an acute illness or hypovolemia that kind of like pushes them off the edge. Presentations can vary like wildly. By true definition, they need to be in shock, but it's really more of a spectrum of disease as opposed to a single point in time. So it really can range from less symptomatic hyperkalemia and bradycardia to profound shock and altered mental status. The common precipitating events are dosage increases of their beta blocker or calcium channel blocker, worsening of their underlying kidney disease, worsening renal hypoperfusion in the setting of like hypovolemia or worsening CHF, and any other critical illness like sepsis that causes hypovolemia. The diagnosis, management. All right, so we're gonna spend time now focusing on these 5 pillars, which try to properly address all the different contributing factors at play in order to ensure that everything's being addressed to reverse all the disease processes at play. So let's start with intravascular volume expansion. So the first part of this multimodal approach is intravascular volume expansion. So BRASH is often exacerbated by hypovolemia, and so careful and targeted fluid resuscitation needs to be used to increase preload and maintain cardiac output. You can use your ultrasound to guide fluid resuscitation. You want to avoid aggressive use of like isotonic like NaCl due to a theoretical, albeit not well substantiated risk of precipitating hyperchloremic metabolic acidosis. And one consideration you could do there is use isotonic bicarb in cases of uremic non-anion gap metabolic acidosis to help mitigate worsening kidney function and the need for emergent hemodialysis. And that was what was like supported in the literature from the bicar ICU trial. After you fluid resuscitate them, you need to address the cardiac membrane. And we love using the term, all right, like cardiac membrane stabilization, but this is something I like came to find as I was doing my research here. It's very nuanced and still very poorly understood. But from my understanding, it's complicated, it's multifactorial, it's still debated in the literature, but there very much is a like physiologic basis with which we choose to address it. So hyperkalemia raises the resting membrane potential closer to the threshold potential. That in turn affords a more excitable myocardium through partial inactivation of the sodium channels, which in turn shortens the potential duration. And that corresponds to your like increased QRS widening, which you'll oftentimes see in the setting of hyperkalemia. Calcium, when you give calcium, it raises the threshold potential, not the resting membrane potential, but it raises the threshold potential, thereby temporarily restoring that electrochemical gradient. And that in turn exerts like a shielding effect on these sodium channels, which makes the myocardium less excitable and less likely to go into a ventricular dysrhythmia. In terms of what calcium to choose, the math is there, but for the same percentage gluconate versus chloride, you get almost 3 times more elemental calcium in calcium chloride. So for your critically ill patient, ideally with central access, so that's not required, reaching for calcium chloride will deliver more elemental calcium in a smaller volume than calcium chloride. Moving on to cardiac output. The next step, right, the next pillar is augmenting their cardiac output. Your first line choice is typically epinephrine. You can start it as a drip, set it at a rate of like 2 to 4 micrograms per minute and titrate to clinical effect. It increases both inotropy and chronotropy. Another one is isoproterenol. It's a pure beta agonist with chronotropic effects. Typical rate is 1 to 20 micrograms per minute as a drip. You can trial atropine. It's likely not going to work, and we'll try to, I guess I can do it here. Atropine's likely not going to work. Does anyone know why?
Where does atropine work here?
Excellent. So it's right. It's an antimuscarinic. medication. And so at what level of our conducting system does it exert its effect? At the AV node. And where is our bradycardia likely stemming from? It's likely infranodal, right? So atropine is going to increase SA node firing rate and AV nodal conduction velocity, but anything infranodal is not going to be touched. So if it's in the proximal conducting issue, atropine is likely to work. If it's a distal conducting issue, it's not going to exert any clinical benefit. So focusing on medications that have channels that are infranodal, two more options are norepinephrine, and you're familiar with your 5 to 30 microgram per minute rate to titrate, or dobutamine at 2 to 10 micrograms per minute. But these should be at least what's like best evidence supporting the literature. Your 4 agents you should be going to increase cardiac output through inotropy plus minus chronotropy. Fourth pillar is potassium shifting. You guys should all be very familiar with this. We just throw a K cocktail at them. And then the last thing is potassium removal. Kaliuresis through like monotherapy or combination therapy, including thiazide diuretics, acetazolamide, and loop diuretics is good. But for patients who are anuric, it's an indication to get emergent hemodialysis. Yes.
Is there any different questions in terms of how they stimulate the sodium potassium ATPase, and which can also help shift potassium?
Because most of them are like pure beta 1 or mixed beta 2 agonists, and that's how it's going to exert most of their effect. In terms of the NAK ATPase you're talking about?
Yeah, it's like if like epinephrine also helps shift potassium by stimulating.
Yes. Oh, I see what you're saying.
Does that work the same way?
I don't know. That's a fair question, given that they have similar mechanisms of action. I don't know. I would have to look into that.
But you want a beta agonist, so epinephrine better than Levenson.
Exactly.
There's more beta agonists than Levenson, which is much more of an alpha agonist. So you want the beta agonist because that's the one that stimulates the sodium potassium bond, which is okay. So I want to talk about one other problem with hyperkalemia in these patients, which maybe you didn't discuss. So people often, I think, mischaracterize a small jump in your creatinine as enough renal failure to cause hyperkalemia. This is not true, by the way. That GFR, glomerular filtration rate, all the potassium that's filtered through the glomerulus is reabsorbed all the time. The only K that ends up in the urine that's excreted from the body is from the distal tubule, and that is determined by urine flow rate. So urine flow rate is the problem with most cases of hyperkalemia acutely like this. Not in dialysis patients who are just taking a lot of potassium, but the patients who are not end-stage renal, who are not on dialysis, who are hyperkalemic, especially men, you should always do a bladder ultrasound because those patients are frequently urinary outlet obstruction. And the best way to treat them is to put Foley in and decrease the obstruction because that will change their renal function, improve their renal failure, treat the cause of renal failure, and they will have a significant natriuresis and polyuria and decrease their K. So I think in males who are hyperkalemic, you should always do a bladder ultrasound and always assume that they have urinary outlet obstruction and treat it appropriately.
All right. For the sake of time, I'm going to skip this. We can come back.
And also the potassium resins, not for acute glaucoma. I don't know why the medicine people.
So that was a point I was going to make. In the acute management, because those take time to work, like if they're no longer altered and they can tolerate orally aspirin, you should not be falsely reassured that that's going to significantly,
It takes 24 to 48 hours, like this is, you know.
The final thing I want to discuss is the role for TVP. So this is kind of a little bit of a deeper dive into like the evidence. So bear with me, but I do think it's interesting. So is there a role for TVP? There were some case reports that mentioned temporary success with transcutaneous or transvenous pacing. One systematic review by Majid et al. In 2023 showed that 33% of patients did not improve enough with medical management alone and did require some form of pacing. The European Society of Cardiology put out like a guideline expert consensus statement, which it's like a cohort of like, experts in the field that kind of look at the totality of evidence and give different evidence-based recommendations with the level of evidence that they think is supported based on what they did. And for they really don't mention much about the role of pacing in unstable bradydysrhythmias, but the general recommendation they give for high degree AV blocks in the setting of acute hyperkalemia and AV nodal dysfunction is that they would largely recommend against pacing if there's a reversible cause that can be addressed. And so in our paradigm here, there were multiple reversible causes that were likely contributing to the bradydysrhythmia, and none of the evidence that they found supports the role of pacing in a bradycardic patient. The AHA, so the American Heart Association and the American College of Cardiology, they put out a similar expert consensus based on the totality of the evidence in 2018. And they actually do address 4 pillars that are much more relevant when it comes to pacing in these patients. So in the acute management of these patients, although overdoses and other antiarrhythmic drugs, such as beta blockers and calcium channel blockers, can cause reversible AV blocks, several studies have shown that therapeutic doses of these drugs are not commonly responsible for the presentation of AV block, and that most patients in this scenario ultimately require some form of permanent pacing. In terms of the acute medical therapy, they reiterate how atropine can be trialed, but is likely to not be efficacious, as it is vaguely relevant a medication, but does not affect conduction below the level of the AV node. They do reiterate the role for beta agonists like isoproterenol, dopamine, dobutamine, and epinephrine in treating the bradydysrhythmia. And then aminophylline in the setting of like bradydysrhythmias due to an inferior MI. As for temporary pacing, and this is where it's most relevant to us, the cause of the AV block should be taken into account in order to consider the timing and necessity of temporary pacing. For example, if your patient's coming in with an inferior MI and they blew their AV node, your time's probably much better spent getting an interventionalist downstairs and activating the cath lab as opposed to setting up to transvenously pace that patient. Alternatively, if they have reversible causes that you're addressing and you're not going to be delaying care by setting up and transvenously pacing, it is reasonable to do it in that situation. There are no controlled trials of transcutaneous pacing outside the pre-hospital setting, and they're oftentimes going to be limited by the high capture thresholds like we addressed earlier, because the underlying acidemia and hyperkalemia make it really difficult to capture electrical energy into mechanical capturing. And so it's, again, I don't want to lose you. It's reasonable to try as long as you're already addressing all the underlying contributing factors at play, and it's not going to delay any definitive care. But you are likely to run into physiologic barriers that may limit its success. That's the overall point I would like to make. All right, so this patient was admitted to the CCU, all right? On his first day of admission, he was weaned off the insulin drip. They were able to slowly down titrate the epinephrine drip in the morning. They continued to hold his AV nodal blocking agents. He got an inpatient echo, which showed an ejection fraction of 67% without any regional wall motion abnormalities. And they just noted dilated RA-LA with mild mitral regurg. On hospital day 2, there was no recurrence of the betacardia. He was kept NPO for a TEE, which showed a similar ejection fraction and a no thrombus. They up-titrated his home insulin, given his A1C of 16, and they slowly restarted his PO metoprolol tartrate. On hospital day 3, they repleted his magnesium for residual hypomagnesemia. He had an episode of AFib with RVR to the 150s that was managed with pushes of IV metoprolol. Hospital day 4 saw more AFib with RVR, but no hemodynamic instability. On day 5, they held his AC and made him NPO for a possible cardioversion with ablation. On hospital day 6, his renal function normalized. It downtrended from a creatinine of 2.1 to 1 with a baseline GFR that was similar 2 years prior in 2023. He underwent an electrophysiological study with successful typical A-flutter ablation and a loop recorder implant. He was started on dronedarone for maintenance of normal sinus rhythm, and they restarted his long-acting metoprolol succinate at this point. And then on hospital day 7, he was discharged with outpatient EP follow-up, which he continues to go to this day. In summary, remember your 6 classifications for thinking of your bradycardic hypotensive patient: infectious, neurogenic, cardiac or structural, toxicologic, environmental, and endocrinologic. Remember that BRASH syndrome is a clinical diagnosis. You should maintain a high suspicion in any critically ill patient with bradycardia and cardiogenic shock on therapeutic doses of their AV nodal blocking medications, and they exhibit some laboratory evidence of hyperkalemia and renal injury. The 5 pillars of treatment for BRASH address intravascular volume expansion, cardiac membrane stabilization, augmenting your cardiac output, potassium shifting intracellularly, and then potassium removal from the body. And lastly, it is reasonable to trial transcutaneous or transvenous pacing for refractory bradycardic shock, as long as you are continuing to address all the underlying factors at play, and it's not going to delay any other interventions that would be definitive in managing their bradydysrhythmia. These are my references, and thank you for your time.